Next, we're going to have Dr. Benjamin Snyder. He's going to talk about hip issues and relation to lower extremity pain. Ben?
My name is Ben Snyder, orthopedic surgeon. I joined the group about a year ago. And I'm going to talk about hip-spine syndrome, how the hip and spine are intricately linked, and patients that have an issue with their hips often have an issue with their back, and vice versa. My background, I'm with Plymouth Bay Orthopedics. I got my engineering degrees from Penn State University in Pennsylvania, medicine and public health degrees from Dartmouth. Did my residency out in Worcester at University of Massachusetts, and did my fellowship with joint replacement surgery out at Stanford in California. So my specialties and area of expertise are joint replacement, redo joint replacements, complex joint replacements, and then trauma. So I have no conflicts of interests. So my objectives are to discuss the relationship between the hip and the spine, discuss evaluation of hip-spine syndrome, and discuss the role of diagnostic and therapeutic injections to determine what really is the pain generator. Is it the hip? Is it the spine? Is it both? So this is the best description that I have found looking through the literature on how the hip and the spine are interconnected. So essentially you can think of the hip and the spine as two hinges that are back to back, like door hinges. And they both have to flex and extend for us to sit down and then stand up. In general, the spine has to flex and extend about 20 degrees, and the hip has to extend and flex about 60 degrees. When you sit down, they both flex to about 80 or 90 degrees so we can sit down. And likewise, when we stand up, they extend. And so how they're linked, if one becomes rusty and does not work, such as in an arthritic or degenerative situation, such as Dr. Leckie was talking about when you have arthritis of the spine, that back hinge will freeze. And so all that motion then needs to come through the hip. And so patients that have a stiff back can have to overcompensate with their hip joint, and they often can develop impingement or pain in and around the hip because they're having to essentially overuse that joint. And conversely, if you have hip arthritis, where that hip becomes very locked, then all that motion needs to come through your back. And that would lead to increased impingement, pinching of the nerve roots. It can worsen any arthritic conditions that you have in the spine. Oftentimes, if patients have back surgery, often the hip might get better. And really importantly, if patients end up having a hip replacement because they have a stiff, bad hip, it often improves their back pain because less of that motion is needing to come through the back. So I hope you understand that. It's a little bit complicated, but that's the best, simplest explanation I could find. So when you talk about hip-spine syndrome, it's kind of been differentiated into three categories. One is simple, when you have pathologic changes to both the hip and the spine, but there is one clear source of the patient's pain. There's complex, when there's pathologic changes to both, but you are unable to determine which source is really the culprit, despite a detailed physical exam. In this situation, I'll go through when an injection might help differentiate. And then there's a secondary, when there's pathologic changes that are interrelated and they often exacerbate the other. And that often we'll also utilize a diagnostic and therapeutic injection in those circumstances to determine, really which one's worse than the other. So this is a very long list. I'm not going to go through all of this, but this is just the different causes of hip and spine pain. And there's causes that are within the hip joint itself. There are causes that are outside the hip joint, but somewhat close in vicinity to that area of the body. There's a lot of spine pathologies. Dr. Abraham and Dr. Leckie have gone through this, a lot of these. And then there's other pathologies, that are often, less thought of and a lot more rare, but things to consider. So how you try to differentiate those is taking a very, detailed patient history. You listen to the patient's story. How did the pain develop? How long has it lasted? What makes it worse? What makes it better? Where is it located? Does it radiate? Is it sharp and stabbing? Is it dull and achy? Is it burning or electric-like? Was there any traumatic injuries, to the hip or the spine in the past, that might have caused it? So you listen to the patient's story, you listen to their symptoms. We also take, a medical and a surgical history. Do they have prior surgery on one of the hip or the spine? Do they have medical issues that might affect that? In hip pathology, patients typically complain of groin pain. They might think they might have sprained their groin, or they might hold their hand in a C shape right around the hip joint. They might complain of clicking or snapping, kind of mechanical symptoms around the hip. And oftentimes they have difficulty, really bending over to put on their shoes or getting in and out of the car, particularly lifting that leg in and out of the car or on and off the bed. Those very sensitive signs to hip pathology. Spine pathology tends to be pain in the buttock or in the lower back. Pain is typically burning or electric-like. That indicates that some of the nerves are irritated. As Dr. Abraham talked about, the shopping cart sign, when pain is relieved by bending over, that helps open up those spaces where the nerve roots exit and reduces that compression and those symptoms. And then the neurogenic claudication, when patients start walking, they walk for longer distances and their legs start feeling heavier. If that gets better with sitting, that's often indicative of neurogenic claudication. Then you do your physical exam and study how the patient walks in and out of the exam room. Do they have pain with putting weight on the hip? If that's the case, it's likely hip arthritis. Do they have a limp, when they're having to compensate or certain muscles aren't working in and around the hip joint? That might make that pain worse. You inspect, you see how are they walking? Are they bending forward? Are they extending? Is there any atrophy noted in and around the back, buttocks or thighs? Do they have any previous surgical scars that might help indicate, what surgery they had in the past that might be causing this? Do they have a leg length discrepancy or pelvic obliquity where the pelvis is actually tilted one side or the other? That can be due to the hip, or it could be due to a scoliosis. You examine the hip range of motion. Arthritis is commonly found with patients that lose internal rotation, so that's rotating their foot to the outside. They lose that motion, and then eventually they lose that motion, trying to bring the foot to the inside, and that's why patients have the pain, putting on their shoes. You palpate different areas to try to discern what might be tender, what might be painful, and then there's several provocative tests, and this is a list of those provocative tests. And you do these, really differentiate, is it coming from the hip, or the spine? I'm not going to go through all of these, but these are often very sensitive and help determine, the etiology. And then diagnostic tests. When you come to see an orthopedist, we often get x-rays because while we can inspect, the skin and surgical scars and any atrophy, we also want to look, what is the shape, alignment, is there any fracture or, degenerative changes within the bone? So when you're looking at the hip, you're getting a frontal view of the pelvis and then also a lateral side of the hip. If you're looking at the spine, you're getting the front, the side, and then also flexion extension views to see, is that spine unstable, similar to what Dr. Leckie was talking about. Signs of arthritis on an x-ray, there's 4 cardinal signs. It's narrowing between the bones, and that indicates that the cartilage is starting to be lost, kind of like the treads on a tire starting to wear out. As that cartilage is lost, the bones start creeping closer and closer together until they're bone on bone. And that's where the bone on bone comes from. You start seeing bone spurs on the sides of the joint. You might see hardening or sclerosis. And then you might see cysts within the bone eventually. If you're looking at the spine, particularly the nerve roots, soft tissues, the disc, get an MRI. The hip, if we think it's some intra-articular issue with the labrum or an extra-articular issue with one of the muscles, tendons, ligaments, then we get an MRI. Often we're getting these, if the x-rays are somewhat inconclusive to what's causing the pain. And then patients that cannot undergo an MRI, either due to severe claustrophobia or a pacemaker, then we can do a CT myelogram to look at those nerve roots and soft tissues about the spine. So this is was in one of the studies that I reviewed. This is a lady, you can see, has a degenerative scoliosis, and the spine surgeons performed a fusion. Her symptoms persisted. Therefore, they went back in and performed another and extended the fusion. Her pain persisted, and then they finally got an x-ray of the hip. And you can see, the right hip there on the pelvis, that ball is completely eroded. It's flattened. It has big bone spurs. It has big cysts. She had a significant hip arthritis all along. So we want to make sure that we make the right diagnosis, and we're not putting patients through unnecessary surgeries that carry unnecessary risks. So to help differentiate, is it the spine, is it the hip, with the help of our physiatry colleagues, Dr. Abraham and Dr. Turan, will perform ultrasound or fluoroscopically guided diagnostic and therapeutic injections, either into the hip joint itself or into the back. And then these are different algorithms that I found in these studies. So if you have a patient that comes in, you get x-rays and they have osteoarthritis of the hip or the spine. If they have a neurologic deficit, that requires a spine consult, because if it's progressive or severe enough, that patient might need spine surgery. If they have groin pain and arthritis in their hip, then we often perform an injection to make sure that it is actually the hip that is causing the symptoms. If they have good pain relief, then we often would recommend a total hip replacement. If they have groin pain and you really don't see a lot of arthritis on that x-ray, then you might consider that MRI. If that MRI is inconclusive, then you still might do a fluoroscopic guided injection. And if they have significant pain relief for that, they might be a candidate for a total hip replacement. But if the MRI finds another cause of that pain, then that's something you would address with potentially non-surgical modalities, including physical therapy, anti-inflammatories, modifying the activities that might provoke it, or even considering extra-articular injections. This is another kind of algorithm that they had. So you take the patient's history and physical. If it's the spine, you treat the spine. If it's the hip, you treat the hip. But if it's really not clear, that's when we inject the hip joint. If they get no relief, that's when you start expanding your differential diagnosis and looking for these other causes. If they get incomplete relief, then you might consider a spine injection to see if patients get relief from that. If their hip pain is relieved, but those spine symptoms continue, then there's a bunch of different treatments or surgeries that you might consider, some with low risk, some with high risk, some with high reward, and some with low reward. But you can see how that diagnostic hip injection is very important to both differentiating, is it the hip that's actually causing the pain? So the benefits of the hip injection, if the patients have a positive result, meaning they have a 50% reduction in pain, then they often will have a successful outcome if they undergo a total hip replacement. This is a very specific test to pathology within the hip joint itself. So what I tell patients, if they're going to be going for one of these injections, figure out what types of situations really cause the pain. And you put yourself in that situation before you go for the injection, an hour or two. And you write down what's that pain number. Is it an 8 out of 10 or a 10 out of 10? You get the injection, and then you put yourself back in that situation, and you again grade the pain. Has the pain not changed at all, and it's still a 10 out of 10? Or has it gone down to a 2 out of 10? So if they get that positive response, then it is likely coming from the hip joint, and we may discuss proceeding with a total hip replacement. So in conclusion, the hip and spine, they're intricately linked as two opposing hinges. If one of those hinges loses its motion, then the other hinge needs to compensate. And that's why you often, as you develop arthritis in the spine, the hip might get worse. You get arthritis in the hip, the spine might get worse. You have to take a very detailed patient history, really listen to their symptoms and their story, take a detailed physical exam, and then you're going to consider x-rays and an MRI if those x-rays are inconclusive to see if it's a simple or kind of a secondary hip spine syndrome where you would have an obvious target of what you would go after. Or if it's a complex, when both show degeneration, both show issues, then that's when we're really employing that diagnostic or therapeutic injection. And if that injection is successful, greater than 50% release of your pain, then that does predict success in undergoing a total hip replacement. And thank you. I guess.